Hello, I'm Dr. Frimpong, and I work at Temple University School of Pharmacy, where I teach oncology and pain management in the therapeutics course. My clinical practice site is in the outpatient setting at the hospital with medical oncology, where I work primarily with patients on oral anti-cancer therapies. And with them, I provide education, monitor for adherence, toxicities, drug and drug disease interactions. So, today we are going to be discussing some of the basic principles surrounding antineoplastic therapies. We will specifically discuss the principles of anti cancer therapy. We'll then go over some of the mechanisms of action, indications, pharmacokinetics, drug interactions, and side effects of some of the most commonly used agents, and then briefly review how to prevent and manage common treatment related toxicities. When it comes to treatment, we have a few different modalities, as you can see in the top diagram of this slide. These include surgery, radiation, chemotherapy, targeted, and biologic therapies. Antineoplastic agents is the umbrella term that best describes the chemotherapy, targeted, and biologic therapies. Antineoplastic agents interfere with the development, growth, and spread of malignant cells. The goals of these therapies may be curative or palliative in intent. A goal of cure is typically achieved if the patient is cancer free for at least 5 years, whereas palliation involves relieving symptoms, improving quality of life, and prolonging survival. Treatment can be administered in a variety of ways. It could be given alone, it could be given before or after surgery, or with radiation, either at the same time or sequentially. So, for example, if radiation could be given first, then once it's completed, the patient would then begin chemotherapy, or this could occur in reverse. We sometimes give 2 or more agents together, and usually, if we do this, we try to include drugs that have different mechanisms of action and or different dose limiting toxicities. So for instance, one drug might have a dose limiting toxicity of myelosuppression, whereas the other drug might have a dose limiting toxicity of neuropathy. Cancer therapy as a whole is cytotoxic. It kills cells, both good and bad ones. Unfortunately, traditional chemotherapy agents like to target rapidly dividing cells. So, in addition to the cancer cells, it can also affect hair follicles, the cells that line the GI tract. So, in the mouth, this could result in mucositis. In the throat, it can result in esophagitis. And in the stomach, we can either see diarrhea or nausea and vomiting. The bone marrow is also affected, and this is where we make our red cells, white cells, and platelets. Therefore, because of its effect on the bone marrow, treatments can be immunosuppressive. And so, for example, if a patient's white blood cells were to be affected by treatment, the patient can be more prone to infection. How we decide who gets treatment and what type of treatment a patient will receive really depends on several different factors, including the overall goal, whether it's cure versus palliation, the patient's age, and if they're able to handle intensive treatment or not. Same thing goes with performance status and the patient's baseline ability to carry out their activities of daily living. So, is the patient someone that shows up to clinic on a stretcher, or is it a patient that is running marathons, very, very active on a daily basis? The other things we look at are what comorbidities the patient has prior to starting therapy. So, do they have diabetes, heart failure? Do they have baseline peripheral neuropathy? These are all things that we need to consider when selecting therapies. We also look at the extent of the cancer. Is it more localized? And therefore, we can employ modalities such as radiation or surgery, or is it more metastatic in nature? And does the patient need systemic therapy? We also look at if there's any elements of renal or hepatic dysfunction, their blood counts, as well as ultimately what the patient prefers or what the doctor is more familiar or comfortable with using. Here are the major classes of antineoplastic therapies. They include conventional chemotherapy, targeted therapy, endocrine or hormonal agents, as well as radiopharmaceuticals. Now, for the purpose of this lecture, we're really only going to briefly review the first three. Here's a summary of the various mechanisms of many of the antineoplastic agents and how they either interfere with cellular synthesis and or cellular function. So we will first review conventional chemotherapy agents. Antimetabolites are cell cycle specific. They exert their actions within the S phase of the cell cycle. Antimetabolites resemble naturally occurring nucleotide bases that get falsely incorporated into DNA, eventually deactivating DNA and halting cellular synthesis. This class is used in a variety of malignancies, including leukemias, lymphomas, and solid tumors such as pancreatic, colon, and lung cancer. They include the pyrimidines such as 5-fluorouracil and capecitabine, which are commonly used in GI malignancies, as well as the purines and purine analogs that are more commonly used for leukemias and lymphomas specifically. And then the third subclass are the antifolates. One of the ones that you may be more likely to see in practice is methotrexate. Antimetabolites as a whole cause quite a bit of bone marrow suppression, as well as gastrointestinal toxicities such as mucositis and nausea and vomiting. Methotrexate is an antifolate antimetabolite that binds irreversibly to dihydrofolate reductase, inhibiting the cell's ability to activate folate. This results in a reduction of thymidine concentrations, which impairs the cell's ability to synthesize DNA. Methotrexate has a wide array of uses. Low doses are used for non-oncology conditions such as rheumatoid arthritis and psoriasis. Intermediate doses are employed in certain types of cancer regimens. And then high doses are typically used for the management of brain tumors or lymphomas. High doses also require monitoring of methotrexate levels, urine pH, as well as the use of leucovorin. So a couple things to know with methotrexate is that this is one of the chemotherapy drugs that can be given intrathecally, where it's injected into the cerebral spinal space. Hydration is also very crucial. Methotrexate doesn't get fully metabolized, and the clearance of the drug is dependent on renal function. So with high doses of methotrexate, you want to make sure that there aren't any drugs that can impair its excretion. Methotrexate also distributes readily into third space fluids like ascites and pleural effusions and can result in prolonged exposure and increased toxicity. It is important to note that methotrexate halts the synthesis within normal cells and cancer cells. And these toxic effects of methotrexate on normal cells can be reduced by administering leucovorin about 12 to 24 hours after the methotrexate is given to rescue those cells. Some of the common toxicities include bone marrow suppression, mucositis, and nausea and vomiting. Our microtubule targeting agents are cell cycle specific as well, and they inhibit the M phase where mitosis occurs. They are used in a variety of malignancies, including leukemias, lymphomas, sarcomas, and ovarian cancer. Today, we're going to focus primarily on the first two subclasses, the vinca alkaloids and the taxanes. Vinca alkaloids, in terms of their mechanism of action, prevent the assembly of the microtubule network, whereas taxanes prevent the disassembly of the microtubule network. The vinca alkaloids include vincristine, vinblastine, and vinorelbine, and they are derived from the periwinkle vinca plant. They are metabolized in the liver, so you want to monitor patients' liver function tests and also monitor for potential drug-drug interactions. As a class, it can cause neuropathy, and it can be either peripheral, motor, sensory, or autonomic in nature. Usually, the neuropathy is symmetrical and it can be irreversible. So, it's really important to closely monitor patients while they're receiving this type of therapy. And the neuropathy is a result of its mechanism of action, as the microtubules play an important role in nerve conduction and neurotransmission. You want to exercise particular caution if the patient has neuropathy at baseline prior to starting therapy, or if they're on drugs such as gabapentin or pregabalin. Those are going to be patients you really want to monitor very closely. In general, the vinca alkaloids with B's in their name, so vinorelbine and vinblastine, cause the most bone marrow suppression. The other thing to note is that as a class, these drugs can result in death if inadvertently administered intrathecally. So it's very important that this drug is only given intravenously. The other thing to know with this class is that they are also vesicants, and this is going to be an important feature to keep in mind when you have patients receiving this therapy, because these are the patients that will benefit from central venous access. Like I mentioned previously, the taxanes prevent the disassembly of the mitotic spindle, rendering it non-functional and unstable, ultimately resulting in cellular apoptosis or cell death. These drugs are associated with infusion reactions due to their excipients, and we see quite a bit of the infusion reactions, especially with paclitaxel. The other toxicities we can see with the class include peripheral neuropathy, myelosuppression, and nail changes. Docetaxel is also uniquely associated with capillary leak syndrome, which leads to fluid retention in various body cavities and various parts of the body. And this particular toxicity can be prevented and managed with low-dose dexamethasone. So this class inhibits the topoisomerase enzyme, which is responsible for maintaining DNA structure during replication and transcription. The agents are used for a wide range of cancers, and they include the anthracene derivatives, the camptothecins, and the semi-synthetic podophylltoxins. The anthracene derivatives inhibit topoisomerase 2, whereas the camptothecins inhibit topoisomerase 1, and the podophylltoxins inhibit topoisomerase 2. As a class, they are non-cell cycle specific, but if you look at the individual subclasses, some of them work in specific areas of the cell cycle. So the most widely used and best understood anthracene derivative is doxorubicin, also known as adriamycin. Is metabolized in the liver, so you want to exercise caution in patients who have hepatic impairment. It does go through the following pathways that I've listed here for your information, and therefore there are quite a few drug-drug interactions that may come into play. Some of the common toxicities include myelosuppression, mucositis, nausea, vomiting. We can also see discoloration of secretions. So usually tears, sweat, urine may change to a pink or orange color. Patients can develop secondary malignancies. In other words, a second cancer can develop after receiving this particular agent, and it's typically leukemia that we see develop years after getting doxorubicin. And then the other major toxicity is the cardiotoxicity. Because of the cardiotoxicity, before initiation, we have to determine the patient's baseline heart function with either a MUGA or echocardiogram. Ideally, the left ventricular ejection fraction, or LVEF, should be greater than 50%. You also want to assess for risk factors. So does the patient have underlying cardiovascular disease, have they received prior anthracene derivative therapy in the past, is the patient elderly, or is the patient a very young infant or toddler. Notably, the cardiotoxicity or cardiomyopathy specifically that we can see with the anthracene derivatives is associated with cumulative lifetime doses, and so you want to exercise caution when the patient starts to approach a cumulative dose close to 300 milligrams per meter squared of doxorubicin. The alkylating agents bind to oxygen, amines, phosphates on DNA and result in inhibition of DNA replication and transcription, mispairing of DNA, and or DNA strand breakage. These drugs are used in a wide range of malignancies and are considered non-cell cycle specific. They also represent the oldest class and include nitrogen mustards. Commonly used agents in this category are cyclophosphamide and ifosfamide. The nitrosoureas, which are very lipophilic, they cross the blood-brain barrier and are thus commonly used in CNS malignancies. We then have our platinum agents, which are notorious for their nephrotoxicity as well as their neurotoxicity. The triazines and other alkylating agents that don't necessarily fall into the other four categories. As a class, these drugs are cytotoxic, myelosuppressive, mutagenic, meaning they can induce mutations, teratogenic, meaning they can harm the fetus, carcinogenic, meaning they can lead to development of a second malignancy or a second cancer. In the interest of time, I will just focus on cisplatin, which is part of the platinum family of alkylating agents. Common toxicities include nephrotoxicity, nausea and vomiting, and this drug is considered highly emetogenic, potassium and magnesium wasting, hypersensitivity reactions, and ototoxicity. Patients who get cisplatin require hydration before and after chemotherapy infusion, as well as antiemetic prophylaxis. And we'll talk a little bit about antiemetics towards the end of the lecture. This slide highlights some of the agents that do not necessarily fit into the classes that we've already discussed today. I've just listed some of their indications and available formulations, but you don't need to memorize this information. Here's another list of agents that don't fit in the conventional chemotherapy classes we've discussed thus far, along with their indications and available formulations for your reference. So the next major class of antineoplastic therapies are the targeted therapies. They include monoclonal antibodies that target cell surface receptors or antigens, as well as small molecules that enter the cell and interfere with the enzymatic functionings of the cell. These drugs play a role in blocking the following mutations, whether it's abnormal expression of growth factor receptors, dysregulated intracellular signaling pathways, defective DNA repair and apoptotic processes, tumor angiogenesis, or epigenetic dysregulation. So biologics stimulate the body's immune system to act against cancer cells. They specifically refer to monoclonal antibodies, cytokines, growth factors, vaccines, as well as enzyme/protein-based therapies. If you see these patients in the primary care setting and they ask about vaccines, in general, it is best they avoid the following vaccines if the patient is actively receiving a biologic. Worst case, I would recommend confirming with the patient's oncologist to make sure it's safe to receive a live vaccine from this list. The concern ultimately is that if the patient's immune system is weakened, they may not be able to mount an adequate response against a vaccine, which could be very problematic if the patient's receiving a live vaccine such as MMR, smallpox, zoster, rotavirus, or adenovirus. Well, first we'll discuss the monoclonal antibodies. They are large molecule drugs that are all administered intravenously, and they're considered biologic. Monoclonal antibodies all end in the suffix "mab". Part of their substem indicates the target specificity or therapeutic use. So, if the drug targets a tumor versus the cardiovascular system versus the inflammatory system. The substem immediately preceding the suffix indicates the antibody type or species of origin. So, for instance, if the antibody is mouse derived, chimeric, or fully human. So, if we look at these next two examples, alemtuzumab targets a tumor that is a humanized monoclonal antibody, versus infliximab is a drug that targets the inflammatory system and it's a chimeric monoclonal antibody. Since late 2017, the naming system of biologics was updated to include a core name plus a hyphenated FDA designated suffix of 4 lowercase letters. So you'll notice that all biologics that have been recently approved will have a suffix ending in 4 lowercase letters that are totally random and are devoid of any meaning. In general, we have monoclonal antibodies that target cell surface glycoproteins, all of which are listed in the first column. These drugs are mainly used in leukemias, lymphomas, and myeloma. We also have drugs that target growth factor receptors and ligands, noted in the second column, in addition to drugs that target the vascular endothelial growth factor signaling pathways, noted in the third column, both of which are used primarily in solid tumor malignancies. And then our final category of monoclonal antibodies are our checkpoint inhibitors, which are also used in a variety of malignancies. You may have seen some of these agents in the media, specifically pembrolizumab, which is also known as Keytruda, or nivolumab, which is also known as Opdivo. Monoclonal antibodies work in a variety of ways. Drugs like rituximab target specific proteins and or receptors on tumor cells. They can bind directly to the receptor and alter downstream signaling pathways. They may depend on macrophages to mediate phagocytosis of tumor cells. They also could depend on natural killer cells to mediate cellular cytotoxicity, or they may involve complement proteins that, once they become active, form a membrane attack complex, which punches holes into the tumor cell and results in cellular apoptosis. This slide is a closer look at the 4 mechanisms I just reviewed on the previous slide. Some monoclonal antibodies like bevacizumab prevent the binding of vascular endothelial growth factor, which prevents angiogenesis. Angiogenesis is involved in the formation and the maintenance of blood vessels. The checkpoint inhibitors block regulatory or inhibitory proteins that are normally responsible for shutting down the immune system. When these proteins are blocked, the immune system becomes reactivated, and the host immune system now has the ability to continue to recognize tumor cells that do not belong. Because immunotherapy agents reactivate the immune system and trigger an inflammatory response, we typically see inflammatory-like reactions in various organs, including inflammation within the brain, known as encephalitis, inflammation of the pituitary gland, known as hypophysitis, inflammation in the lungs, also known as pneumonitis, the liver, known as hepatitis, pancreatitis, colitis, myocarditis, just to name a few. To manage this particular toxicity, we use high-dose corticosteroids, typically 1 to 2 mg per kg of prednisone or an equivalent corticosteroid. Some monoclonal antibodies target cell surface antigens but deliver radioactive substances or toxins directly to the tumor cell of interest. These drugs are known as immunoconjugates, sometimes referred to as antibody drug conjugates, and they involve a monoclonal antibody that is chemically linked with a cell killing substance. An example of a drug classified as such is brentuximab vedotin, used in certain types of lymphoma. Some monoclonal antibodies bring the immune cell and the cancer cell together. It forms a complex. The T cell becomes activated, and then it results in tumor directed cellular cytotoxicity. And an example of this drug is blinatumomab. Common side effects of monoclonal antibodies include infusion reactions, which can range from fever, chills, to shortness of breath. Some of the toxicities are related to the targeted antigen or protein. And so, for instance, vascular endothelial growth factor inhibition or VEGF inhibition can lead to hypertension, bleeding, impaired wound healing, thromboembolic events, or proteinuria. Whereas the epidermal growth factor receptor inhibitors or EGFR inhibitors can lead to rash or other cutaneous reactions since it affects the epidermal growth factor receptors that are found within the skin. Kinase inhibitors, for the most part, end in the suffix "ib". Many of them are oral therapies, and these drugs target an enzyme or protein inside the cell. When the drug binds to the kinase, it prevents phosphorylation and subsequent activation or deactivation of the enzyme. The table on the slide includes a listing of the kinase inhibitors that are currently approved in the US, and we'll talk about some of the commonalities in a few moments. Here is a legend for all the targets listed on the previous slide for your reference. As a whole, kinase inhibitors share common characteristics. Some of the agents must be administered on an empty stomach, whereas others are best taken with a meal. There are also drug and food interactions that can have an effect on the efficacy or the side effect profiles of these kinase inhibitors. And then finally, even though these drugs are targeted in nature, they can commonly cause fatigue, diarrhea, hand-foot syndrome, stomatitis, rash, and liver dysfunction. The multikinase inhibitors target multiple receptors, proteins, or enzymes. They also share common characteristics with the other kinase inhibitors. Many of these are oral agents and are utilized in certain types of renal cancer, liver, and thyroid cancers. Here is a list of the multikinase inhibitors currently on the market and their respective indications for your reference. Here are some additional targeted therapies that are currently on the market for your reference as well. The last and final group of antineoplastic agents we will discuss today are the endocrine therapies. All have generally low organ system toxicity, and they're used for cancers under hormonal control, or in other words, cancers that are stimulated by the overproduction of hormones. The selective estrogen receptor modulators inhibit the uptake or prevent the binding of estrogens and androgens. The aromatase inhibitors prevent the conversion of androgen to estrogen, and drugs in this class include letrozole, anastrozole, and exemestane. And then our gonadotropin releasing hormone agonists indirectly decrease testosterone production. We also have the gonadotropin releasing hormone antagonists that directly shut down testosterone production, and the drug that's currently FDA approved in this category is degarelix, also known as Pharmagon. We then have our anti-androgens that bind to the androgen receptor and prevent testosterone from stimulating prostate cell growth. Our first generation anti-androgens are bigalutamide, flutamide, and nilutamide. And then we have some newer second generation anti-androgens on the market: enzalutamide, apalutamide, and darolutamide. Abiraterone is an androgen synthesis inhibitor that inhibits enzymes expressed in testicular, adrenal, and prostatic tumor tissues. This drug also inhibits the formation of testosterone precursors. And then the last category of our endocrine therapies are the corticosteroids. Steroids are used in combination with antineoplastic therapy for the management of leukemias, lymphomas, and myeloma. They are also helpful in preventing nausea and vomiting when administered before or with chemotherapy. And the side effects include high blood pressure, hyperglycemia, fatigue, and if used for a while, we can actually see osteoporosis develop. With all the potential toxicities, patients are usually on other supportive care medicines in addition to their antineoplastic regimens. They may be on hydration. They may be given antibiotics, especially if they're receiving antineoplastic therapies associated with severe myelosuppression. And then some patients who have metastatic lesions to the bone or in the bone may receive bone modifying agents such as zoledronic acid, pamidronate, or denosumab. The majority of the conventional chemotherapy agents are dosed based on body surface area and take into account both height and weight. Some therapies are weight-based. Targeted therapies tend to be fixed dose. And for carboplatin specifically, the dose is calculated based on the patient's renal clearance to prevent toxicity. The Calvert formula is commonly used to calculate carboplatin dosing. During the course of therapy, monitoring for efficacy and safety is crucial. For efficacy, we obtain imaging studies to assess response, assess symptoms, look for drug-drug interactions, and if patients are on oral anti-cancer therapies, adherence becomes very important as well. Toxicity-wise, we review labs prior to treatment, and in general, their absolute neutrophil count should be above 1,500 and their platelets above 100,000. We monitor their renal function to ensure dose adjustments aren't warranted and monitor the patient for treatment-related toxicities. And when necessary, we would reduce, hold, or discontinue their cancer treatment. So why is monitoring so important? These drugs have a high potential to cause toxicities and errors, and they are also considered, because of this, high alert medications that carry a heightened risk of harm. There are several routes of administration, not only intravenous and oral, but some agents are given in ways to achieve local or localized concentration, whether it's administered intrathecally, intraperitoneal, intravesicularly, or topically. These agents are also very complex in the way they're given and their nomenclature. Some drugs are given in combination where one drug is given every day, but then the other drug might be given 7 days on, followed by 7 days off, and then repeat. The agents also come with intricate labeling and warnings to ensure proper handling. So on some of the bottles or some of the IV preparations, you'll see hazardous, cytotoxic, as precautions for whoever may be coming into contact with the drug. We really don't want unintentional exposure during dispensing, compounding, administering, receiving, or transporting these agents, which is the reason for some of the intricate labeling. With antineoplastic agents, we can see toxicities from head to toe. So anything from neurotoxicity, pulmonary, cardiotoxicity, in addition to infertility and loss of reproductive capacity. Chemo Man is one of my good friends, and it really helps with remembering some of the toxicities associated with conventional chemotherapy specifically. Nausea and vomiting is one of the most prevalent and feared side effects associated with cancer therapy. There are various agents that can cause nausea and vomiting, including cisplatin, dacarbazine, in addition to high doses of doxorubicin and carboplatin. The risk of emetogenicity of agents helps us determine who would benefit from antiemetic therapy. It indicates the percentage of patients that can have nausea when no prophylaxis is administered. So, for instance, greater than 90% of patients will experience nausea and vomiting if they do not receive any prophylaxis when administered an agent that is of high emetic risk. Non-pharmacologic options for the prevention and management of nausea and vomiting include eating smaller, more frequent meals throughout the day instead of a large meal, eating foods that are at room temperature, avoiding foods that are very greasy or spicy, avoiding caffeine, and then sometimes behavioral intervention may be helpful, especially if the patient has what's known as anticipatory nausea. The drugs we use for the management of nausea interfere with the binding of neurotransmitters that are released when chemotherapy activates the neuroreceptors in the brain in the central pathway and or in the gastrointestinal tract through the peripheral pathway. These drugs include the neurokinin 1 receptor antagonists, corticosteroids, our serotonin receptor blockers, dopamine antagonists, benzodiazepines, cannabinoids, as well as our atypical antipsychotics. The key thing to note is that antiemetics are most effective when given proactively and administered around the clock until the chemotherapy is complete. Mucositis is commonly associated with the antimetabolites such as 5-FU, capecitabine, and methotrexate, as well as the kinase inhibitors. When it is solely in the oral cavity, it is known as stomatitis. These therapies cause mucosal injury, damage, or ulceration, usually a few days to weeks after starting treatment. And the biggest concern is the impact it has on the ability for patients to continue to eat. When mucositis occurs, we typically dose reduce or we may delay treatment. For prevention, ice chips or ice popsicles might help. Good oral hygiene is paramount, keeping the mouth clean, rinsing after each meal with water or salt water or baking soda and water. Eating soft, moist foods at room temperature helps, along with avoiding spicy and acidic foods. Unfortunately, nothing cures mucositis, but we do have drugs that can help cope with this toxicity. Non-alcoholic based rinses such as magic mouthwash, viscous lidocaine, and steroid suspensions may be helpful. Some patients may require opioids because the mucositis is so severe. Diarrhea is mucositis of the lower GI tract, and with the management of this, hydration is crucial. Patients can eat small, more frequent meals. Electrolytes should be closely monitored when patients are having diarrhea, and we can prescribe drugs such as loperamide or Lamodal if patients are exhibiting symptoms that are beyond control. There are other types of diarrhea we could see, including cholinergic related diarrhea, which is associated with irinotecan or Iran to the can. This usually occurs within the first 24 hours of receiving the irinotecan infusion and is best managed with atropine. There's also colitis, which we can see with the checkpoint inhibitors such as pembrolizumab or nivolumab, and this particular type of diarrhea is managed with corticosteroids. Some of the cutaneous toxicities we can see include hair loss or alopecia. This typically occurs 2 to 3 weeks after the first dose of chemotherapy, and the hair does grow back once all chemotherapy is said and done. It may grow back a different color or texture, but it will come back. And unfortunately, we don't have anything to treat or prevent the hair loss. Nails can become brittle or weak with chemotherapy. Some of the drugs that I highlighted today are the taxane, so paclitaxel and docetaxel can cause those nail changes. Hyperpigmentation can be seen with drugs like capecitabine, and the diagram at the top of the slide is an example of what this hyperpigmentation may look like. Rash can be seen with some of the kinase inhibitors and drugs that target the epidermal growth factor receptors that are in the skin. We can also see rash related to allergic reactions or hypersensitivity reactions from some of the chemotherapy or monoclonal antibodies that are administered. Hand-foot syndrome involves peeling, swelling, sores, redness, tingling, or numbness that occurs in the hands or the feet. This can occur with our kinase inhibitors, but also more commonly with 5-fluorouracil and capecitabine. Some drugs are photosensitive, and there are some chemotherapy drugs that are associated with what's known as radiation recall. So with radiation recall, what happens is after the patients receive the chemotherapy agent, so one of the drugs that causes radiation recall is doxorubicin, an inflammatory reaction develops in an area that had been previously radiated. So a patient may have gotten radiation 10 years ago. Yesterday they got doxorubicin, and today they're starting to notice this inflammatory type reaction that looks a little bit, resembles a sunburn. Extravasation involves unintentional or inadvertent leakage or installation of fluid out of the blood vessel into surrounding tissues. This is caused by irritants or vesicants. An irritant is an agent that causes aching, tightness, or inflammation of a vein, but doesn't cause tissue necrosis, whereas a vesicant causes blistering, severe tissue injury, and tissue necrosis. For prevention, good administration technique and use of central venous catheters are recommended for vesicants and should be considered for irritants. Vesicants should never be given in the hands or wrists, and extravasation kits should be readily available. To manage the extravasation, antidotes plus or minus a warm or cold compress may be employed depending on the causative agent. Myelosuppression is also known as bone marrow suppression and includes neutropenia, thrombocytopenia, and anemia. Antineoplastic agents, as well as radiation and cancer itself, can cause myelosuppression. Myelosuppression results in a decrease in many of the blood cell counts. The complications related to myelosuppression include infection, bleeding, and respiratory distress. For prevention and management, we dose reduce or delay treatment if the patient's absolute neutrophil count is less than 1,000 or their platelets are less than 100,000. We may consider a blood transfusion if their hemoglobin is less than 7 or the patient is symptomatic, whether it's fatigue, shortness of breath, difficulty breathing. Platelet transfusions are given if platelets range anywhere from 10 to 20,000 or the patient is experiencing a life-threatening bleed. The erythrocyte stimulating agents such as Procrit or Aranesp are reserved for cancer patients who have a hemoglobin less than 10 and are receiving palliative chemotherapy or radiation due to the increased risk of thromboembolic disease, mortality, and tumor progression. So they don't recommend giving ESAs to patients who the intent of their chemotherapy or radiation is cure. Other precautions that are necessary include good hand hygiene, minimal contact with animals or other sick contacts. And then for neutropenia, the use of colony stimulating factors like myeloid growth factors may be necessary. Myeloid growth factors stimulate the production, maturation, and activation of neutrophils, granulocytes, monocytes, macrophages to increase their migration out of the bone marrow. Because of its mechanism in inducing this inflammatory-like response, we tend to see bone pain as a common side effect. The available products include sargramostin, also known as leucine, as well as filgrastim and its biosimilars, which are listed for you here. Other myeloid growth factors include pegfilgrastim and its biosimilars. Something to note is that with pegfilgrastim and its biosimilars, these are only indicated for the prevention of chemotherapy-induced neutropenia and not for treatment. This case brings a lot of the concepts and principles we discussed today together. So let's say AH, who has a past medical history significant for metastatic bladder cancer, atrial fibrillation, and hypertension, presents to the hospital emergency department with fever and vomiting, which started a few days ago. Notably, his last cycle of chemotherapy, which includes methotrexate, vinblastine, doxorubicin, and cisplatin, was administered 9 days ago. He has no known drug allergies, and he's on the following medicines at home. In terms of pertinent findings, patient is hypotensive, febrile, and has some evidence of mucositis. Looking at the labs, his potassium and magnesium are low, creatinine's elevated, white cells, hemoglobin, and platelet counts are all low, and his LFTs are also elevated. So which of the following treatment-related toxicities are pertinent in this patient's presentation? Select all that apply. So patient has evidence of electrolyte abnormalities. His potassium and magnesium are low. His serum creatinine is also elevated, so he has evidence of renal injury. His LFTs and his bilirubin is also elevated. And then the patient also exhibits anemia, thrombocytopenia, and neutropenia. So overall with MVAC, which includes methotrexate, vinblastine, doxorubicin, and cisplatin, we can see autotoxicity from the cisplatin, mucositis from methotrexate, which is an antimetabolite, and maybe also some of the other chemotherapy drugs on board, heart failure from doxorubicin, an anthracene derivative, nephrotoxicity from cisplatin, a platinum alkylating agent, myelosuppression from chemotherapy in general, but potentially from the antimetabolite methotrexate that's in the regimen. And finally, peripheral neuropathy from the vinca alkaloid class. In terms of resources, there are guidelines on screening, surveillance, disease state management, as well as supportive care that are available at a couple different professional organization websites. The best resource that is free for all healthcare providers is the National Comprehensive Cancer Network, or the NCCN guidelines. I highly recommend taking a moment to set up an account so that you have access to a wide array of resources if you ever end up encountering or working with patients who have malignancies. A lot of the information from today's lecture was taken from the various references listed within the slide. All right, well, that concludes today's lecture. Please feel free to contact me via email if you have any questions, and I provided my email address on this particular slide.